Here's a couple of other examples. This patient, his wife is a dentist, he fractured a tooth. There was an attempt to go ahead and do a root canal. It couldn't be saved. At that point, we're using a easy extract system, placing a screw and a pin in, and this is essentially a jack system. This implant was removed. This rests on with impression material on the adjacent teeth, and this essentially is a scissors jack that is used to go ahead and atraumatically extract the tooth. Kind of an easy way to take one of those out. So this is the tooth extracted at this point, and now we have a 2mm placement and placement of the implant. So this is the implant in place. Again, you know, a cap, temporary. Patient leaves again with the tooth. The radiographic appearance looks stable, and at 1 week post placement, this is what we have. You can see the tissue already starting to remodel at that point. You know, around this, when the temporary is removed, this is the patient at 1 week, 1 month. Nice tissue formation, 2 months post-placement. And so this patient has, you know, 2 months later is in better shape than the day that he came in. Here's another example of what you can do with some of these. This is a patient that's in his early 70s, had a root canal 50 years ago, had a fractured tooth, has a fistula that's present here, an incision remotely to this, and going ahead and lifting that up. There's soft tissue over that root, removing the area of the fistula and the flap, and we have a fractured root right at this area that looks like a small explosive device went off in this pretty substantial fracture. So we're left with partial loss of the lingual plate and almost full loss of the length of the root on the facial. In this case, we used a longer implant, a 3mm implant again, and placing it down, because it's an 18mm implant, although there's about 8mm of threads exposed here, we can go ahead and place it down into some bone, collecting the bone from the burrs, or going ahead and grafting that site, and then placing that allograft over it, and then going ahead and using a freeze-dried memorized allograft over the top of that, over the native bone, to go ahead and build that up, and then using a piece of dermal matrix or alloderm to go ahead and place, so using the tissue punch here, and essentially making a poncho, if you will, designing this implant and carving it into the shape we want, and placing it over the top so that we have this laying over the bone where we have the defect around the implant and on the lingual, so that we're replacing the soft tissue. You can see the edge of the alloderm here, and we're repairing that area where we removed the fistula at the same time. At this point, we're back to making a temporary. So creating a temporary on that tooth, and then this is the initial healing. Tooth looks pretty good at this point. And this is what the patient looks like at 3 months. This is the radiograph at 3 months. It looks like we've got good initial healing. This is the patient. I'm sorry, these were sent to me. They're not the best images, but this is now at 5 years, and we seem to have a good result in that case. So what can we conclude at this point? That narrow one-piece implants showed some bone loss initially, but long-term, over the first year, it stopped. It may be related to that design. These implants compare very favorably when we compare them to the traditional wider two-piece implants that we're used to using. The aesthetics were very good, and they seem to have very good maintenance of bone, and so they may be an effective choice for areas of small, narrow spaces we need to get into. There's an excellent tissue response. Patient acceptance is very good because they love the fact that you put the implant in and immediately temporize it. And the data, certainly seems to lend toward that. Now, the exciting news is the creation of a two-piece 3.0 implant. And the importance of this is it offers restorative flexibility in narrow spaces. So whereas the one-piece implant was one piece and all you could do was prepare it, now you have an implant that has some improvements over it. And the main improvement is the prosthetic design. The second significant improvement with this implant is the fact that now there is laser ablation or microchannels that are cut into the top. So there's no longer that machined area in a transition zone, but now there's a oriented roughened surface with this laser lock surface that the bone and the soft tissue likes to adhere to. So here's the restorative flexibility. Previously we had an implant that basically had a chimney on it, and this was essentially what the one piece was. Now you can get an aesthetic abutment of different heights. You can get an angled one. You can get a locator on it. There's many more prosthetic options. So this is a significant benefit, to the armamentarium. Now, one of the questions is when you go to a 3mm 2-piece implant is it strong enough? And this is the 2 3-piece implants that are on the market. And, this one with the laser ablated surfaces, the laser locked implant, has greater strength. And so that may be potentially important for us comparing, as we select an implant. So here's the implant specifications. It comes in a 10.5, 12, and 15mm length. Now this is important because the 10.5 is very useful, because we're limited with the one-piece implant of 12, 15, and 18, but having the shorter one allows more flexibility. The top of the implant is laser locked, and so that it has its laser ablations, and that zone is about 2.1 millimeters, and so that we can go ahead and place that either a little above the bone or a little below. It really doesn't matter in that regard. And again, it's basically the same implant with the square threads and no cutting flute, so it has no machined area at all on this implant. So the advantage here may be if we compare the anatomy of a tooth to an implant. The difference is that on a tooth we have these connective tissue fibers that insert into the root, whereas an implant, they kind of move around the surface of a machined surface but don't actually insert. And so that, as we all know, on any given tooth or implant that we have on a tooth, we'll end up having less pocket depth than we do on an implant, simply because there's not this attachment that's firm onto the root surface above the bone in a dental implant. If we look at that in another way, we can look at the probe penetration on a natural tooth. So a periodontal probe comes down and it hits this connective tissue attachment. And it may be this connective tissue attachment, by keeping this healthy and not inflamed, that prevents the bone loss around natural teeth. So if we could mimic that attachment, which we don't have on an implant, where the probe goes much deeper, and that's why we always see deeper probing depth on an implant, if we could get the connective tissue to attach to the implant at the top above the bone, we may be able to prevent that crestal saucering that we sometimes see in implants. So this may be an effective strategy to go ahead and do that. So these laser microgrooves on the surface actually allow connective tissue to attach above the bone. By allowing that, it may mimic what we have on a natural tooth and make the bone loss that is sometimes seen around the junction of an implant limited, because of this ultrastructural attachment of the connective tissue actually inserting onto the surface of the metal. So this, as opposed to the one-piece implant, this is a significant improvement, because instead of having that machine surface, and we know that bone and non-mineralized connective tissue don't really like a machine surface, this highly oriented laser ablated microchannel surface that the connective tissue, both in the soft tissue and the bone, will actually adhere to that, and allows, in a case like this where you have a changing crest of bone, to not be too concerned about the placement. It's okay if the implant is a little above the crest of the bone. Again, this is a simple drilling sequence like we looked at a little bit earlier, starting with a 2mm starter drill to go ahead and go through the cortical plate, the 2mm depth drill. There's a crestal bone drill to go ahead and use this. Unless the bone is very dense, I wouldn't use this. There's also a bone tap to go ahead and thread the implant. Again, unless you have extremely dense bone, I would skip that one too. So this becomes essentially either a 1 or a 2 drill approach, either going 2 millimeters or 2, then 2.5, and then placing the implant. So the steps involved then are to take the 2 millimeter starter drill and go ahead and place that in and make an initial osteotomy. Then the second step is to evaluate the angle and position. And so you have a couple of tri-end pins here that are 2 millimeters on one end, 2.5 on the other, and then have a band here that's 4 millimeters at the hub. So they're 9 millimeters in length, so you can go ahead and look at how that is and relate that to the adjacent anatomy and decide this one's at a 15-degree angle to go ahead and see if you need an angle above it. This third step then is to go ahead and pick up a 2.5 millimeter drill, and I like these extended shank drills because it allows you to get into these tight spaces in between teeth a little bit easier, and I prefer that over a drill extension because there's less chatter when you go ahead and do that. So 2.5 and then placing the implant. And so this implant can be put in with a handpiece, or you can use a ratchet and a square driver. You remove it from the vial, place the apex of the implant into the osteotomy, and then you insert it at about less than 30 RPMs to go ahead and put it in place. Okay, so let's take a look at one of these implants going in. This is a relatively easy procedure to go ahead and do. So this is a patient that has lost a tooth. He's a little bit medically compromised. He has a seizure disorder, and he has a little bit of a tremor, and it probably wasn't the ideal patient for us to pick for this video, but certainly, so despite the fact that he may have a little wobble in his tongue, we can get a feel for what we're doing. So we're starting with just a basic crestal envelope incision is all that we really need to do to go ahead and access this bone. Now you can see that this patient has already had some bone loss from some periodontal disease before this tooth was lost, has some root exposure on that area. And we can open this side up and look at the existing bone and the roots adjacent to it, and so we can see that we have about a little over 4 millimeters, 4.5 maybe of width, and probably almost 5 of space in between, maybe 4.5 in that direction, 4 in the other, to go ahead and place it. So we're limited in the implants we have. Now, the advantage of using this starter drill, I want you to look at the tip of it here, where it's kind of shaped to a point like a chisel. So because this implant, that you're going to use only one drill, maybe two, to place that, you want to go ahead and get it in exactly the same spot because there's not a lot of room to adjust it. So you go ahead and adjust this until you get the point firmly down, and you can press that sharp point down on the bone, hold that spot, use the long angle of the drill to go ahead and mark your position, and then you can go ahead and extend this down. Now the reason why I like the long shank drills here is you can see how easily it fits in between the adjacent teeth, and you have lots of room in the anterior, and you can use this to go ahead and check for the angulation and make sure that we're placing that implant in a parallel fashion. So this is now the 2 millimeter starter drill coming up on 12 millimeter length at this point. Because of the recession that this patient has and the bone loss in that area, we may want to leave this implant with a little bit of that laser lock surface a little bit above the bone. The second step we said was putting in one of these parallel pins, looking at the adjacent anatomy, looking at the space in between the teeth, maybe taking an intraoperative radiograph right now, looking at the position of where we are in reference to the adjacent roots. Then moving to the 2.5. Now, if this is, you can see this, is only going from 2 to 2.5, so this cuts very quickly. coming down to length on this implant. Now, in the maxilla, I would probably stop 99% of the time at the 2mm drill and go ahead and place the implant using the 2.5. Now we're going ahead and using a bone tap. I almost never use this. We only use this for the sake of making this video, really, to demonstrate the use of it unless the bone is very dense. And now we're simply using the handpiece to go ahead and put the implant in. You can see the implant is threading its way down very easily. We're coming down here, and you can see that we have this laser bladed surface right at the top, and we can go ahead and leave that at that point. Okay, then I'm going to just move this along just a little for you. We can use a ratchet at this point to go ahead and finish it, and you can see these dots that are on the ratchet that orient the hex so that we know where the position of the hex is. Inside the cap is a cover screw that we can go ahead and place on top of the implant, and that essentially completes putting this implant in. So in real time, roughly, it's about a 5-minute procedure to go ahead and place one of these implants and solve what would be a very difficult restorative problem otherwise. And so that certainly has something that you can use. You know, I'd probably give yourself a little more than 5 minutes the first time, but maybe 15. But you can certainly get to the point where you can be in and out of one of these cases in 15 minutes pretty easily. So again, the steps that this is basically a simple envelope flap, then going ahead and taking the starter drill, which is with a chisel point, bringing that down to depth, looking at where you are, verifying the angulation and position with a paralleling pin, going to the 2.5 for the final osteotomy depth, if based on the anatomy and based on the density of the bone, and then taking the implant directly from the vial and placing it into the bone. Okay, and then coming back, and in this case, the advantage of the 2-piece is that we could use it like the 1-piece and immediately temporize it in an area of aesthetics based on our initial stability of the implant placement, or we could go ahead and bury it and use an alternative temporary and come back and uncover it. In this case, this is just a straight abutment that we used for a temporary. Put that on and prepared it back, checked to make sure that we had appropriate clearance, and then fabricated a temporary for this patient. Okay, and this is another example of using a 3mm 2-piece implant and the advantage of some of the abutments that have anatomical contours on them to go ahead and restore one of these teeth in a relatively narrow space. So this is a useful implant for areas that are very tight, and certainly is something that is a benefit to have in your armamentarium. So conclusions then on the 2-piece implant. Now, we've used the 1-piece implant for a period of 6 years and have studied that more extensively, and have used the 2-piece one for only about a year. But the 2-piece implant has all the advantages of the 1-piece, plus the added flexibility of the varying prosthetic components that you can have. You know, you have multiple healing options with the 2-piece, and plus it's added the benefit of the laser lock surface as opposed to that machine surface. So it's basically got all the advantages of the 1-piece and a few more that really go ahead and improve upon what was there before. Okay, I'd like to thank you very much for your attention. I know you have some questions and some other issues, and I'd like to thank both Dental XP for hosting this and for BioHorizons for supporting a lot of the science that went behind it. Thank you very much.